Good afternoon, everyone. We're just going to give it another minute here to let folks load into the call, and then we'll get started. All right. Happy Wednesday. I'm Jessica Rigler from Blue Cross Blue Shield of Arizona, joined by my colleague, Dr. Sherry Brown. And we're here to support facilitation for this session. Thank you all for being here for our March Arizona Community Grand Rounds, Avian Influenza in Arizona, updates and recommendations. This is a really timely and very popular topic, so I'm excited to dive into the session today and hear from the fantastic experts. Before we get going with them, though, I'd like to introduce them. We have a team from the Arizona Department of Health Services here. Dr. Joel Tariquez is the cross-cutting medical director of the Bureau of Infectious Disease Services and the Bureau of Immunization Services at ADHS. He's an internal medicine and infectious disease specialist who completed his training at the University of Arizona College of Medicine in Tucson. He also had the unique opportunity to get additional medical training at MD Anderson in Houston and National Jewish in Denver, and has the certification in infection control and hospital epidemiology. Joel served as the medical director for transmissible diseases and tuberculosis control officer in Coconino County from 2015 to 2023 prior to joining ADHS. We're also joined by Reshma Newpain, who is our food and waterborne disease epidemiology program manager at ADHS. She completed her Bachelor's of Science at the University of Massachusetts and her Master's in Public Health and Epidemiology and Biostatistics at the Boston University School of Public Health. Before she joined ADHS, she worked as a research coordinator at the University of Massachusetts Medical School and joined ADHS in 2021 as a wastewater surveillance epidemiologist, where she worked on building up the wastewater surveillance program at the state and providing assistance on food and waterborne disease surveillance. In early 2023, she transitioned into her current program manager position and oversees the foodborne and waterborne disease program and wastewater surveillance. And finally, we're joined by Liam Hicks, who's the program manager of vaccine preventable and respiratory disease epidemiology with the Bureau of Infectious Disease Services at Arizona Department of Health. Liam completed his Bachelor's of Science in Biology and Biochemistry at the University of Wisconsin and his Master's in Public Health and Hospital and Molecular Epidemiology at the University of Michigan. With over 7 years of experience in epidemiology, Liam's seasoned in studying patterns, causes, and effects of health and disease conditions within population. And he's also passionate about collaborating with interdisciplinary teams to develop evidence-based public health strategies that effectively address health challenges and promote the overall well-being of the public. So with that, we'll let our panel dive into the content. Liam, please take it away. And as a reminder, to everyone here, please use the Q&A function to send questions our way throughout the presentation. At the end of the session, we can begin answering questions. At any point, you can put your questions in the Q&A. All right, Liam, go ahead.
Good afternoon, and thank you for the introductions, and to Blue Cross Blue Shields for inviting and hosting this call for us to provide an avian influenza update in Arizona. Next slide. To overview the presentations today, you'll be hearing from myself, where I plan to briefly overview influenza and where avian influenza fits into the influenza landscape, and provide an overview of the current situation to set the scene for Dr. Tariquez, who will be discussing clinical considerations and provider recommendations. Reshma will follow up with an overview of enhanced surveillance methods public health is currently utilizing for avian influenza surveillance, and will conclude the presentation. Without further ado, let's get started. Next slide. So why do we care about influenza that primarily affects birds? To answer that, let's begin by overviewing the influenza virus. The influenza virus is a shifty little virus that's good at its job being to infect the host, replicate, and to infect a new host. Influenza presents with two main types, influenza A and influenza B. Influenza B is characterized by lineages, of which B Victoria is currently the only lineage circulating. Influenza B is also only found in humans and mutates at a slower rate when compared to influenza A. Influenza A is characterized by subtypes, which are different combinations of surface proteins known as hemagglutinin and neuraminidase, so the H and N proteins. There are 18 different hemagglutinins and 11 different neuraminases known. In humans, the seasonal subtypes are H1N1 and H3N2. However, influenza A does not only impact humans, it affects a variety of species, such as cats, birds, pigs, bats, cows, and these different subtypes impact these animals. However, a reassortment event could occur, leading to transmission in a different species, leading to an influx of infections due to lack of immunity in said new species. This was observed in 2009 with H1N1, otherwise known as swine flu. Next slide. If you've been following the news the past few months, you might have seen some headlines like this. Next slide. Or this. Next slide. There has been really only one topic that has been dominating public health news as of recent. And side note, when I made this slide deck, when I drafted it, this was true. Since then, measles has entered the chat. But we wanted to provide an opportunity to you to update you on avian influenza and its current epidemiology. Next slide. So wild waterfowl are natural hosts for influenza A viruses. Next slide. As we discussed earlier, there are many subtypes to influenza A viruses. All known subtypes of influenza A viruses, except for two only found in bats, can infect birds. Influenza A viruses are categorized into two types when they infect birds. So that's the low pathogenicity avian influenza viruses, or LPAI, and high pathogenicity avian influenza viruses, or HPAI. Next slide. Classification as low pathogenicity or high pathogenicity is based on the virus's ability to cause morbidity and mortality in poultry, specifically chickens. Most avian influenza is considered LPAI and only causes asymptomatic or mild infections in poultry. The clinical picture of HPAI in chickens is very different. Most HPAI outbreaks spread rapidly amongst flocks and have a 90 to 100% mortality rate in birds. All highly pathogenic avian influenza strains have either an H5 or an H7 hemagglutinin protein. Next slide. Currently, there is widespread circulation of highly pathogenic avian influenza A H5N1 in wild birds. The predominant clade of avian influenza H5N1 in North America is 2.3.4.4b. The virus began causing sporadic outbreaks in commercial and backyard poultry flocks starting in February 2022. This map represents all wild bird detections for highly pathogenic avian influenza, the majority of which are H5N1. Next slide. So why is it so widespread, and how did it end up in Arizona? The answer is the migration patterns. Arizona lies within a major migratory bird pathway known as the Pacific Flyway, highlighted in this map on screen in red. Each spring and fall, an estimated 1 billion birds migrate through the Pacific Flyway. Many of these species can act as a carrier for HPAI H5N1, meaning they can be infected with the virus but do not become ill, so they can rapidly spread the virus to other birds through their droppings and respiratory secretions. Next slide. These wild birds, as I mentioned on the previous slide, can spread the virus to other birds through their droppings and respiratory secretions. These other birds can be birds associated with someone's backyard flock or birds that are associated with larger operations such as a commercial facility. Since February 2022, HPAI H5N1 has affected 162 million poultry across 51 jurisdictions. To provide context on the overall size of the U.S. poultry flock, there are more than 378.5 million egg-laying chickens in the United States. And in 2023, more than 9.4 billion broiler chickens and 218 million turkeys were processed in the United States. And this was data from the USDA National Agricultural Statistics Service. Next slide. Spillover from birds to mammals is not uncommon and ranges in the severity of symptoms from asymptomatic to severe disease and death. There is a lot of information presented on this map, but the main message I want to communicate is that we have detected avian influenza in different types of mammals across the United States, but generally these are considered dead-end hosts. without any evidence of ongoing transmission from mammal to mammal. However, in 2024, we did identify mammal to mammal transmission occurring in one species. Next slide. In March 2024, H5N1 infection was first confirmed in the U.S. dairy cattle in the Texas Panhandle. The genotype circulating in dairy cattle, B3.13, is likely the result of a single introduction from wild birds that adapted to cow transmission. Next slide. Since then, it has evolved, and to date, there are 972 dairy herds that are affected across 17 states. This was as of February 23rd, so that might have changed a little bit since then. In cows, H5N1 can cause decreased milk production, changes in milk quantity, decreased feed intake, diarrhea, lethargy, or fever, but most infected cattle do recover. Additionally, dairy cattle can shed virus in milk and therefore might potentially transmit infection to other mammals via unpasteurized milk. Next slide. So how did this novel virus in cattle spread so quickly? Genomic and epidemiological studies have found several factors influencing the spread of H5N1 genotype B3.13 between dairies and other agricultural settings. Next slide. Animal movement can, go back a slide. There you go. Animal movement can lead to the introduction of virus to a new herd and rapid spread of the virus between cows can occur. Additionally, an operating dairy has a lot of daily movements of people, vehicles, and equipment on and off the farm. The virus may leave the farm, for example, and the milk headed to a processing facility or on the boots of a worker who also works for another farm. From there, the virus can spread to new farms. Geographic proximity also plays a factor, as some poultry farms have been seen to have spillback from the dairy farms of B3.13. Next slide. This graphic on screen, produced by the CDC, does a good job illustrating and summarizing the current transmission patterns of H5N1 in the current outbreak. As of now, the risk to the general public remains low, and most human infections are associated with close contact with infected birds or cows. No human-to-human transmission has been documented. You can see on screen that humans, as of right now, are, like I mentioned before, dead-end hosts, as well as cats. So lastly, I don't have a slide dedicated to this since this is relatively new information that came out, but the CDC has recently released a risk assessment of H5N1 to humans on February 28th, 2025. And we'll be sure to include the link in the resources following the presentation, but I wanted to highlight some high-level takeaways here. So as I mentioned before, CDC assessed the likelihood of infection for the general US population to be very low. To date, there has been little evidence of genetic changes that suggest adaptation to humans. The risk posed by H5N1 viruses to humans in contact with potentially infected animals or contaminated surfaces or fluids is moderate to high. Of note, any individuals in this population, risk will vary depending on the use of workplace controls, including personal protective equipment, the nature and frequency of exposure, and the time spent in contact with the infected or potentially infected animals or contaminated surfaces or fluids. Additionally, the likelihood of exposure is higher among people consuming raw, unpasteurized milk from infected animals. Although the chance of people acquiring H5N1 virus infection from consuming raw milk is not clear at this time. And then lastly, to note, Arizona has surveillance infrastructure in place to detect symptomatic human cases of H5N1, and these stem from the main pillars of influenza surveillance. So public health conducts regular monitoring for influenza viruses and illness activity, reviewing data from case reporting, public health laboratory monitoring, clinical laboratory trends, emergency department visits for ILI, and wastewater surveillance. Early detection of novel influenza, such as H5N1, allows for measures to be implemented quickly to reduce opportunities for onward spread. Next slide. And then with that, I will hand this presentation off to Dr. Tarikas to cover the human aspect of avian influenza.
Thank you, Liam, for that excellent presentation, and thank you everyone for allowing us to talk to you about this very timely topic, H5N1. When I was working on this presentation, I think that we cannot keep on going without really talking about how interesting the history of H5N1 with us on this most recent outbreak is. I had to phone a friend, and Dr. David Engenthaler shared this magnificent slide with me, um, just because it's just too much to go over that whole history. But anyways, I think that interestingly enough, I think that going through the most recent number of cases here in the country, we know that back in January 2022, we had the first detection of H5N1 in wild birds. That was the first detection ever since 2016. By a month after, February 2024, the first outbreak was noted in turkeys, basically in farm turkeys, which was slightly of a concern, especially after a couple months after we saw the first human case in the United States, specifically in Colorado. By time went by March 2024, we started seeing some cases of H5N1 detected in dairy cattle, mostly in states such as Kansas and Texas. A little bit after, by April 2024, second human case was detected in Texas. Two more cases by May, and then it was proven to have some cow-to-cow transmission back in May 2024. By June, FDA basically put out that warning that drinking raw cow milk was of significant concern for transmission of H5N1. By September 2024, the first human case was reported with no known contact to either poultry or dairy cows. By December 2024, severe human case was detected in Louisiana, and by January 2025 this year, the first human death in the United States was noted due to H5N1. Next slide, please. So basically, what we need to know, and this is basically what I mentioned when it comes to H5N1, first human case is one of the hallmarks, the highlights of this most recent outbreak. And then again, by February 2025, CC reported more than 68. And I think that the most recent update is up to 70 cases and one death in Louisiana associated with H5N1 infection in the United States. We know that there are several circulating genotypes of that H5N1 clade 4B in wild and domestic birds that also have some relationship with other wildlife, domestic animals, some other mammals, cattle, and humans. Next slide, please. So what happens with H5N1? I think that as providers, one of the most important things that we would ask is, what is it that happens whenever we have a patient that is infected with H5N1? So think of influenza. Think of any of the severe influenza cases that we probably saw back in 2009 with H1N1. Onset of symptoms will be quite rapid, around 3 days after exposure. On an average, that would be 2 to 7 days. And most of the patients will have very mild disease. Most of the patients will recover without any significant need for severe or invasive medical intervention, such as intubation, mechanical ventilation. So most individuals will have very mild illness, presenting with conjunctivitis, mild fever, cough, sore throat, runny nose, muscle or body aches, headaches, or fatigue. Some individuals may progress into moderate to severe illness, which means higher fever, shortness of breath, difficulty breathing, mental status changes, even seizures. Those individuals that may have some degree of immunocompromise may develop some severe complications, not only pneumonia and respiratory, but also progressing into multi-organ failure, sepsis, septic shock, meningoencephalitis. That would be the exception of the number of cases, but still something for us to be aware of and highlight, especially if there is significant risk factors associated with possible transmission of H5N1. Next slide, please. Some articles are very interesting, highlighting the symptoms associated with H5N1. In this particular article from the New England Journal of Medicine, they do list different symptoms, different clinical presentation. What was of most interest to me is that 90% of those cases of H5N1 will present with conjunctivitis. Also, in addition to that, 33% of the cases associated with H5N1 will present with conjunctivitis only. No respiratory symptoms, but just conjunctivitis. It is interesting that most of those individuals that were noted to have conjunctivitis were exposed to poultry. Less likely, those individuals that were exposed or that acquired the infection through exposure to cattle were having symptoms associated with eye inflammation or conjunctivitis. 40 to 60% of individuals develop a fever. Around 36% of those individuals infected with H5N1 showed respiratory symptoms. Again, highlighting the fact that conjunctivitis was mostly the predominant symptom in most of the cases. Only 7% of the total cases that were included in this analysis were noted to have non-conjunctival symptoms. So presenting only with respiratory symptoms, around 7% of those cases. So again, not to be repetitive, but conjunctivitis seems to be more than likely the rule for these cases of H5N1 infection. Based on this analysis, the total duration of symptoms was somewhere between 2 and 5 days of duration. Next slide. So transmission, we know that the period of contagiousness for a person with mild illness due to avian influenza is very similar to what we see with regular seasonal influenza. People happen to be most contagious during the first few days of their illness. Some individuals with lower immune system or immunosuppression may have more severe infection and also have higher levels of virus or a higher viral load, which may cause this virus to be highly transmissible for a longer period of time, even several weeks. Luckily for us, next slide. Luckily for us, there's no evidence of human-to-human transmission of H5N1. Certainly, there has been some cases reported where there has not been an identified source for the case, but no proven human-to-human transmission as of today. Again, when it comes to novel influenza viruses, things change rather quickly. So more development, more surveillance to occur before we provide any additional information regarding the transmission events associated with H5N1. Next slide. So when it comes to evaluating an emergent influenza virus, part of that risk assessment is for us to determine if this virus happens to be susceptible to the available antivirals. Why is this important? Because we know that even though we may be hit significantly with a wave of infections, that's certainly a possibility. It is slightly reassuring that we have antiviral medications to treat this virus with. So as of today, we know that there are two classes of antiviral medications that will act against influenza. One being neuraminidase inhibitors, including oseltamivir or Tamiflu, peramivir or zanamivir, as well as a cap-dependent endonuclease inhibitor, which is only one drug so far, baloxavir. So part of the analysis on this study was published in Clinical Infectious Disease. The authors basically conducted a genotypic and phenotypic screening of H5N1 that was circulating globally in 2022 to 2023. Both screening techniques indicated that those two most predominant clades were largely susceptible to both nucleoside inhibitors as well as the endonuclease inhibitors. There was no evidence of reduced inhibition or highly reduced inhibition associated with neuraminidase inhibitors or with the endonuclease inhibitors. So overall, the frequency of resistance of influenza A H5N1 against those neuraminidase inhibitors was extremely low, around 0.78%. and resistance reported to the endonuclease inhibitors was also extremely low, even lower, 0.54% or so. So we can safely assume that most of the antiviral medications against influenza that we have available commercially will be active against H5N1. Next slide, please. So our recommendations for providers. If we happen to identify someone that has respiratory symptoms compatible with influenza A, as well as significant risk factors, meaning exposure to animals or to symptomatic confirmed or probable human cases of H5N1 or avian influenza, first step, we need to make sure that we isolate those patients and follow your infection control recommendations. Definitely start empiric antiviral therapy. Usually, and the go-to medication would be oseltamivir or Tamiflu, which is readily available. Notify the state and local health department if you're suspecting a case, so we can provide you with additional recommendations regarding testing. Use appropriate PPE, collect respiratory specimens, and then again, coordinating with your local health department for additional testing and diagnostic support. If the initial diagnostic test does not subtype H5N1, and we need to make sure that influenza A subtyping diagnostic testing is ordered within 24 hours of hospital admission for anyone that is positive for influenza A. Again, as always, we will recommend to consider other possibilities. Not every patient that comes into the hospital with respiratory symptoms and a risk factor, or if they happen to have a bird, a pet, that does not mean that they have avian influenza. Always consider the normal, regular stuff that you will find in the community. Always consider ruling out other possibilities such as COVID-19, RSV, among others. Next slide. And I will pass this on to Reshma.
All right. Okay, sounds good. Thank you, Dr. Terriquez. All right, everybody. Now I'm going to be diving into the additional surveillance, being conducted for monitoring pathogens, including H5 subtype here at ADHS, which is the wastewater surveillance. So to begin, I'm going to give a brief overview of what wastewater is and how does wastewater surveillance work. So wastewater meaning, and I'm sure most of you know, it's water from any household use, so sinks, our showers, bathtubs, right? Toilets, our dishwashers, but it could also be, water from stormwater drains and any, water usage through our businesses or industries can kind of contribute to. So the pathogens that are excreted, right, in human feces or urine by basically symptomatic and asymptomatic individuals. So the pathogens sheds in wastewater, that wastewater kind of travels through the sewer system and makes its way to our sewer system, and those wastewater samples are then collected from sewers or right at the wastewater treatment plant. So those collected samples are then sent off to laboratory for testing. So basically we're testing, right, the amount of, for example, virus in that wastewater samples that were submitted and collected. So once those testing is done, those results are then reported to public health or the epidemiology team, who will then use that data to monitor pathogen trends within the community, right, as well as use it for any public health actions or, conducting any sort of mitigation measures or for situational awareness. So just giving that brief background and an overview of how wastewater surveillance works. Next slide, please. All right, so now let's talk more about the wastewater surveillance program here in Arizona. So our wastewater surveillance program is a statewide program. We participate in the CDC's National Wastewater Surveillance System, which is also short for NEWS, which was started back in 2021 in response to COVID-19 pandemic. So in 2021, we received funding from the CDC, and we kind of began our wastewater surveillance program here with the established partnerships that we have with our city partners and academic partners who are already conducting wastewater testing. And then we kind of slowly started to expand our program. So at this time, we have around 24 wastewater sites here in total, which covers about 50% of Arizona's population. Samples are collected twice a week from almost all our sites. And then we have sites within around 7 counties. So you can take a look at the map. I've kind of dedicated the little triangles, and those are our counties where we have sites, and we're monitoring wastewater at this time. And so like I mentioned previously, we started partnering with our academic partners for wastewater testing. However, in 2023, our state public health laboratory onboarded wastewater testing, and we began conducting that testing in-house. And let's see. Okay, so some of the pathogen targets we're currently testing for here at the state is SARS-CoV-2. We're also testing for influenza A and B. So anything that tests positive for influenza A is also subtyped for H5. And I would also like to mention that this testing, right, it will detect that H5 subtype, but does not detect specific strain of H5. And also we're testing for RSV and some of the other targets that are on, on our line for testing would be Mpox and arboviruses. So these are the two pathogen targets that we're kind of looking into for onboarding on our end. Awesome. Next slide. All right, so now I'm going to dive a little into the H5 detections that we saw in wastewater this past year and kind of walk you through that timeline of events and our efforts. So around the second week of November, and this is something that Liam also alluded to in his presentation early on, right? So there was an outbreak of H5N1 in the state. So we had a report of H5N1 outbreak in Pinal County by a commercial poultry farm. So the first detections of H5 in wastewater samples occurred shortly after. So one detection was in Coconino County in Flagstaff, and then it was followed by a few detections in Maricopa County and City of Tempe and City of Phoenix. Then there were some subsequent detections that kind of quickly followed. So now we then, began to ask why were we seeing these detections, also around the time when we're seeing an outbreak of H5N1 in the state. So we kind of quickly notified our county partners, also our internal programs here. So Liam's team, we have our vector-borne team as well. We kind of got everybody together and closely also collaborated with our wastewater treatment plant partners, because they're the ones who kind of have an understanding of how these sewer systems are kind of set up and what could be possibly contributing to the sewer system. So basically to identify any potential sources of H5 contributing to the sewer system. So as some of these discussions, notifications were kind of happening, we also work with Translational Genomics Research Institute, TGen North, and they kind of let us know about the cytochrome oxidase testing, and this testing would, potentially confirm the presence or absence of chicken or wild bird and cow DNA. So we kind of wanted to utilize this as a resource, and some samples from Maricopa and Coconino County were sent off to TGen to conduct this testing, and DNA from wild bird and chickens was identified in those selected wastewater samples. So with the insights from this testing and consistent positive detections that we were seeing, our county partners issued a press release to inform the general public and kind of enhancing that community awareness about wastewater detections for H5 here in Arizona. So, you know, this investigation really highlights the coordination and collaborations that we had with internally, our state lab, our other laboratory partners, our county partners, as well as our you know, city and our wastewater treatment plant utility partners, and also serves as a good example of how wastewater data can be used for possible public health action awareness and possible mitigation measures. All right, next slide. Okay, so now I'm going to dive into, you know, just wanted to show you all some trends that we're seeing in wastewater at this time for influenza A and B. So you're basically seeing this graph here. We're plotting the sample collection date here, and then kind of looking into the average concentration. So the amount of virus that were detected in wastewater samples that we're collecting and testing. And then here you'll also see a red arrow that's pointing downward. So this was when our lab changed the lab method. So we kind of had a change in the assay that we were using, and that happened around October of 2024. So if you're looking at influenza A, we kind of saw a little bit of peak around December time, and kind of a high peak around January of 2025 and slowly coming down. So just wanted to kind of share that trend here. And then for flu B, also kind of seeing a slight small peak around December, and going into February and March, kind of we were seeing some of that peak there for flu B and wastewater. Next slide, please. All right, and this is our trend for H5 in wastewater. So like I mentioned earlier, right, we started seeing those detections around November, kind of went into December, and we saw quite a few detections around that time. And going into January, we had a fewer detections, and kind of that slowed down kind of walking into February, and we have not seen any detections since then. So it's been a little slow there at this time, but just wanted to kind of show you some of those trends here for H5 as well. Next slide, please. All right, so that concludes our wastewater presentation as well, but just wanted to mention that wastewater is definitely an evolving field. I think we're all learning about it, but I think there is that potential, right, for early detection, and I think that utilization of it, I think we're still learning, but I think some of these examples that I've shared with you also serves as a good example of how wastewater data could be used along with our other public health data for possible public health action and awareness. So this slide here, I'm not going to go into all the resources here, but just wanted to let you all know that we've included these links, and in the slides includes combination of our wastewater, our epidemiological and clinical resources, most of the information that we've also covered today. So please go ahead, feel free to, after the presentation, whenever you have the time, go into some of these links, and hopefully these will be useful, and kind of getting more information if you're interested in looking into it a little bit further. Next slide, please. All right, so that concludes our presentation. Thank you for allowing us to present, share our work. Thank you all for your time and listening in. We've also included our contact information here, so please feel free to connect with us, reach out to us if there are any questions in the future. Thank you all so much.
Thank you so much to our panelists. I really appreciate the information and updates around avian influenza. We did receive a couple of questions in the chat that I'd like to have anyone on the panel address. First question is, Are there certain populations that are at higher susceptibility of being infected with avian influenza, excluding immunocompromised individuals?
Liam, do you want to take that question, or do you want me to jump in?
Sure, I can take that. Sorry, I was just getting off mute there. So individuals that would be at higher risk for avian influenza are really anyone that has that exposure to the infected animals and facilities that we talked about. So poultry facilities, backyard poultry flocks. They work in dairy cattle industry and some of those agriculture facilities, and potentially anyone that has contact with or may be handling sick or infected birds. So maybe some hunters or individuals out in the public are handling a wild bird that may be sick or has passed away. They may be at an increased risk. Additionally, vets, as they're kind of processing these animals as well, might be at increased risk if they're not adhering to PPE.
Thank you so much. The next question is regarding transmission. So thinking about transmission, there has been some suggestions in the media that humans and cats can potentially spread this avian influenza to each other. Can you talk about any evidence around this?
I can take that one too. So currently, there is no evidence of cat to cat or cat to human or human to human spread of H5 bird flu at this time. The cats that have been infected have come from exposure to wild birds. So outdoor cats hunting these wild birds or picking up the dead animals and exposing themselves there. And then there was also a large, I guess, exposure for cats that had exposure to raw milk pet food. And that led to them becoming exposed and becoming infected.
Very helpful information. Thank you, Liam. Also, revisiting the surveillance system pillars that you discussed, Liam, which public health entities are gathering this data specifically, if you can speak to that, as well as how do these entities share information between one another to form a full picture of the situation?
Sure. So, as far as gathering data in Arizona, influenza is laboratory reportable. So, we do receive all positives for influenza that have been run at a lab. So, we take that information along with we have syndromic surveillance that has any facility that reports into Essence. We're able to pull influenza-like illness data from those facilities and kind of aggregate it up to the state level to see trends for that. Additionally, we have virologic surveillance implemented throughout the state. It's called Roadmap, and you can, if you want to learn more about it, you can search that in Google, and it will take you to a CDC site. But essentially, what it is, it's a surveillance infrastructure that is set up to sample positive influenza viruses throughout the state, increasing. So it's a sliding scale. It does increase as uh, lab detections increase also, but the goal of the infrastructure is for labs to send in a certain number of specimens each week, and then for the state lab to do subtyping on those specimens. So there's a whole bunch of calculations behind it for, I guess, thresholds of detection. But that is how the three cases that were identified in the national perspective were identified through that system. Um, and then how we kind of I guess disseminate this information is we have a public dashboard that allows anyone to go in and answer their own questions on influenza surveillance. It also covers COVID and RSV as well. And we have a respiratory summary report that covers any highlights such as pediatric deaths for flu, the big trends for the state, and then it's also including H5 detections as well. I think that covers most of it.
It did. Great job, Liam. Thank you. Okay, next question is, can you explain why the ramifications of wastewater showed poultry and wild bird H5 DNA in counties where no disease has been reported?
Yeah, that's a good question. And I think that's an answer we were looking into as well. Unfortunately, we weren't able to determine the sources. However, the testing that TGen kind of did kind of gave us an idea of what we were seeing in the samples. That's why we were we wanted to kind of collaborate with our utility partners, the wastewater treatment plant partners, to try to get an idea of how the sewer system is kind of set up, what's contributing to it. One of our also assumption would be, right, the migratory birds, and they're kind of contributing to the sewer system, and somehow it's making its way to the wastewater treatment plant, and kind of we were able to kind of detect that in the sample. That could be a possibility, right? And then backyard flock. I know there are some areas where people do have backyard poultry, so that could have been contributing to the sewer system as well that we were picking up. So I think there were some possibilities that we were thinking through, but unfortunately we weren't able to determine the source. But some of those testing did help us kind of to have a little idea of what we were seeing, and that was the wild bird and poultry, the chicken DNA that we saw.
Thank you so much. Makes sense. Next question is regarding if we're interacting with patients or members of the public who are concerned about becoming infected with H5N1, what is the main messaging we should provide them?
To our patients, I think that the most important message would be reassurance that as of today, there's no evidence of human-to-human transmission. I know that it does cause a lot of panic, but at the same time, whenever we are protecting ourselves in the hospital, wearing PPE, etc., we do it because with influenza A viruses, there's always going to be the possibility, there's always going to be a possibility of virus mutations. So we are protecting ourselves and others just based on a possibility prevention that by the time that the patient ends up in the hospital, that we, basically that we're thinking about this virus potentially being mutated and causing that human-to-human transmission. But as of today, there's no proof that it's being transmitted from one person to another.
That's wonderful. There is a follow-up question to that, actually. Do we expect eventual human-to-human transmission in some form, even if not widespread?
Again, I don't think that we have the answer to that question because even when H5N1 was first described, we know that this was a virus very specific to birds. With time, mutations allow this virus to spill over to mammals. And so we know that mutations happen and that it could happen, but as of now, that has not been proven.
Okay. And do we know how long H5 can survive outside of the host?
It's variable depending on multiple circumstances. In general terms, 24 to 48 hours, that is kind of roughly the amount of time that this virus would survive in surfaces. It is one of the risk factors, though, even if you're not in close proximity to the sick or ill bird, that if you're just cleaning the environment because of surfaces or just the dust of that environment, that you could acquire that infection. So we know that the duration would be probably 24, 48 hours, maybe slightly longer, depending on other environmental factors.
Wonderful information. Thank you. And last question that we got from the audience was a recent article on emerging microbes and infections suggests that an antiviral resistant avian flu has emerged in Canada. Can you please discuss monitoring strategies we have in place here to detect antiviral resistant spread and your level of concern around this?
So we're talking about the H275Y or 275Y mutation that was identified in a very small number of cases in Canada. Basically, this protein mutation causes the virus to be resistant to the neuraminidase inhibitor, so oseltamivir. Luckily for us, it only conveys resistance to that specific medication or that group of medications, the neuraminidase inhibitors. We still have baloxavir, which is the endonuclease inhibitor that will not be that will be active against that specific virus. So obviously, surveillance, syndromic surveillance, and when it comes to influenza A virus in general, samples are submitted on a regular, looking into antiviral resistance. So we're always monitoring this with assistance of federal bodies. So I think that monitor occurs, and obviously, when it comes to clinical application of that information, if again, very rare mutation, and if that was to happen, we have alternatives to treat it because there's no mutations identified to those endonuclease inhibitors.
And just to add to Dr. Tarika's on the surveillance side of it, so all animals that are tested and do result as non-negative for H5 are sent to the CDC and to the National Vet Lab for sequencing. So we're able to determine kind of the sequence pattern for those animals as well that would help elucidate whether they have resistance or not.
That's wonderful to hear. That was the rest of our questions. Thank you so much to our panel. Are there any concluding thoughts you'd like to share before we wrap up?
I think that from my perspective, reassure our community and our community partners and our providers that the Arizona Department of Health Services, we continue working and partnering with all of you, providing education, any clinical support that might be needed, or if there's any questions regarding testing, by all means, please reach out. I think that the main message here is, again, not to be repetitive, but that human-to-human transmission is not a concern, overall low risk for the community. So make sure that you educate your patients, provide them with that feedback and reassurance that as of today, there's really no significant level of concern for our general community.
That makes total sense. Thank you so much. I'm going to turn it over to Jessica to give information and closing remarks.
Great. Thank you so much, Dr. Brown. Dr. Tarikas, Reshma, Liam, your insights were incredible today. Thank you so much for sharing with all of us. To all our participants, slides and today's recording will be available on the NARBA Institute's website in the next few days. If you search Community Grand Rounds, you can find them. Please use this QR code that you see on the slide now to get the link so you can redeem your CEUs for this event as well. We're pleased to be able to offer those. And as we conclude, I'd like to extend a large thank you to our partner, the NARBA Institute, who are instrumental in making Arizona Community Grand Rounds possible, and specifically to Mary Jo Gregory, Dr. Mark Carroll, Carla Berg, Jennifer Pierce, and Dr. Sherry Brown for their collaboration on this particular session. To all of you, please stay tuned for our next Arizona Community Grand Rounds coming up on April 2nd, where we'll hear about Arizona's congenital syphilis outbreak and strategies for prevention and outbreak management. Thank you all so much for joining us today. We hope you enjoy the rest of your week.
Thank you.
Thank you.